antimicrobials by promoting the selection of the optimal antimicrobial regimen, dose, duration of therapy, and route of administration. An example of this is in St. Luke's Medical Center, Global City, where I practice. They have a program that aims to decrease antibiotic resistance and improve patient outcome by promoting judicious use of antibiotics. So culture results are gathered and summarized from hospital microbiology lab annually for the antibiogram. So this is a local antibiogram. Then this data is analyzed by the IDS or ICS group to develop recommendations for empiric antibiotic therapy for common infections in our hospital, and this includes intra-abdominal infection. So in our 2023 antibiogram summary, we have a significant ESBL prevalence, 26% in coli and Klebsiella, carbapenem-resistant Pseudomonas, 19%, but it's lower compared to national and regional averages. So it emphasized the need for stewardship and tailored empiric therapy. So again, these are the common causes of intra-abdominal infection in our hospital. And these are the most common organisms that we obtain and analyze annually. So the most common, of course, for intra-abdominal infection is still E. coli, followed by Klebsiella, ESBL, E. coli, Pseudomonas, and multiple drug-resistant Klebsiella pneumoniae. And these are 2023 resistance rates for E. coli, Klebsiella, and Pseudomonas. So this is still lower than the Philippine ESBL rate, much lower. So based on these local antibiograms in a hospital, these are the antibiotic recommendations for moderate risk extrabiliary complicated intra-abdominal infection and for high risk extrabiliary complicated intra-abdominal infection with the following alternative drugs or agents. So you have to have your own local data, antibiograms, and recommendations in the hospital where you practice, because organism resistance rates and susceptibility might differ from hospital to hospital. So in terms of stewardship lessons, we know there's a rising SBL and carbapenem resistance in our country based on several data and surveillance. There's higher resistance pressures due to limited resources, and some pearls is that broad spectrum coverage not always better, culture before treatment, they escalate based on culture results, and shortened therapy duration. This is also highlighted in the 2024 SIS guideline. So for day course, after adequate source control, and because of the high ESBL rates, our hospital usually require carbapenem sparing choices. So lesson is use local antibiograms, avoid unnecessary carbapenem use, adopt stewardship principles to your own resource setting.